I can't think of a better way to start that conversation than to hear from Kim Bimestefer, the Executive Director of the Department for Healthcare Policy and Financing. Executive Director Bimestefer, if you don't know at least who she is, you're probably in the wrong room. But you are in for a treat, and I would ask you to help me welcome her to the stage now.
So thank you, Carter. I appreciate you. Good to see everybody. We are here in person. Can we get a round of applause for each other? And CHA, thank you for, where's CHA? Where's Catherine? Thank you for sponsoring the cocktail party tonight. With HICPUF, we have a 4% administrative budget, which means we can only afford about a good box of wine. So I am looking forward to seeing everybody else tonight. So my job is to tee up all of the sessions that are going on today and weave in a little bit of Medicaid, because Medicaid, as you know, is covering 1 in 4 Coloradans, so we have some influence. One of the most important things that we want to talk about today, and there'll be a session on, is the end of the public health emergency. So we have the honor of taking care of about 450,000 more Coloradans, most of which lost their job during the COVID-induced economic downturn. So we're up 36%. So at the end of the public health emergency, see that red line that goes up so dramatically? The bulk of those people are inside Medicaid expansion. And I want to ask Marivelle, you didn't know I was going to do this, but stand up, please. Marivelle is overseeing a ton of our end of the public health emergency work. So if you have questions, you're welcome to ask Marivelle, and I want to give Marivelle and her team a shout out. CMS has said we are the leading state in the nation in our preparedness for the end of the public health emergency. But there are a whole lot of beating hearts and beautiful belly buttons that will go from Medicaid to other types of care, and we need to hold their hand, knowing that we're covering right now 43% of the births, 43% of the children, 1 in every 4 Coloradans. Holy cow, so we need to hold their hand and make sure that they know how to get from A in Medicaid. Roughly about 315,000 individuals, we believe, will need to be moved from Medicaid to some other type of care. So we ask for your partnership in that. Our shared goal is to keep the uninsured rate at about 6.6%. There's also an economic factor. So first, most priority, biggest priority, the beating hearts, the beautiful belly buttons, help them get from yesterday to tomorrow and stay covered, especially during this continued pandemic, especially during flu season, especially with RSV, 5 types of COVID out there. We want to make sure that people also with chronic conditions keep their coverage and get the care that they need to hit those shares goals that Carter just said. So 1.7 million people over the next 12 months, once the public health emergency ends, will be redetermined as business as usual. What will happen, though, is the calls coming into counties will go way up. And counties just like you are struggling to hire folks. We're all struggling to hire folks. So we're going to see a little bit of service pinch at our counties. We ask you to have some grace for our counties. We're doing everything we can to partner with them to prepare them for that. Everything else is pretty awesome. We've done a ton of investments in innovations. We're very excited to bring those innovations with perfect timing to bring us in this period of great importance. I also want to recognize that it has an economic impact, and that is through the public health emergency, we got 6.5 points of extra funding from the federal government. To you, that means $950,000 or close to $1 billion over 10 months above what we needed to cover those extra 450,000 people, which went to a General Assembly and helped them manage the budget and balance the budget. So now we have the Tabor impact. There's more money coming than we were allowed to spend, which is why you're getting those beautiful checks, which means not enough money for the things that we want to do as our elected officials and the Joint Budget Committee and all the departments, while those big monies coming from the federal government, just the $1 billion from us, will turn off. Okay, so this is a big deal financially as well. And I want to recognize to families, it's not just a coverage issue. Those who are on supplemental nutrition assistance programs, that's SNAP, that's food assistance, the amount of monies that SNAP will drop when the public health emergency turns off is about $134 million a month. About 50 million of the $134 million a month that Human Services gets to help people with food insecurity. That's about $600 million as well on the financial front. So this is a big deal all around. So the other area that COVID has impacted and the entirety of public health has been impacted is our workforce. Those who are in the workforce, can you raise your hand, the healthcare workforce? Healthcare workforce, can we give a shout out and a round of applause for everybody that's in the healthcare workforce, frontline? So 4 to 5 times more moms have left the healthcare workforce, or left the workforce in general than dads. Really significant. So to healthcare, where 70% of the workforce is women, it's had a duplicative effect. In certain areas like nursing, where 90% of the workforce is women, a quadruple effect. And our healthcare owners, like hospitals and physicians groups, have felt this. Women in the workforce themselves and their families have felt this. So the state has stepped up in collaboration with the provider community, $26 million over the next 2 years to pay for free education in certain areas to help stimulate and revitalize and get people into the healthcare workforce, to take care of each other, to get us through these next few years, to help transform the workforce and find a new tomorrow as we realize what do we need to do to have the workforce of tomorrow. So wonderful degrees like CNAs, certified nursing assistants, EMTs, phlebotomist techs, medical assistants, dental assistants, really a wonderful opportunity. On the right-hand side of the slide recognizes the issue that we just said with women. This is 2 courses paid for in community college or technical colleges that help people be able to get into the child care business. This is a game changer. I want you to see it in 2 ways. One, what I just said with the health force. The second, to interrupt generational poverty. This is a once-in-a-lifetime opportunity, and I need every single person in this room to understand my words. Every single person in this room, please download this slide when the slides come out to you. Print out these posters if you are a physician, office group, a hospital. Play these messages on your TVs in the waiting room. Put these charts up in the midst of your break rooms, your patient office visit rooms, because we have the ability to not just see Medicaid patients as individuals who need the care. We have the ability to see Medicaid patients as the healthcare workforce of tomorrow. This is a once-in-a-lifetime opportunity for people who are low income. Thank you very much for seeing both sides of this amazing opportunity. And I want to thank each and every one of you who helped us pass this legislation and get this funding. With that in mind, can I ask for those who are elected officials to raise their hand and to stand up? I see Senator Fields. We love you. We thank you. Can we give it a round of applause to all the individuals who are helping to drive the policy in the future? Senator Field, your leadership is awesome. Okay, heading into winter, we're going to have a few challenges. RSV is back and roaring. RSV, for those of you who don't know, is a respiratory condition. It's often around the schools. It's fine when kids get a little older. But when you're an infant, this can be really struggling and frightening for your family. Often the kiddos end up in children's hospitals. Presbyterian, St. Luke's Hospital, which is Rocky Mountain Children's Center. So we have a real issue when RSV starts. This is a troublesome year for RSV. The flu season is back, right? And we have 5 different types of COVID going around. So today, this is beautiful. We're in person. I don't see any masks. This is a fabulous time. As it starts to move, I'm just asking you, please do your part. They might need to put on some masks when you're going into big groups and small settings, right? So little, very contained dinners and bars and things like that. Think about that. Please do your part. Flu shots, please do your part with your boosters. All right, now I'm going to move to care delivery and some of our systems. We'll talk about hospitals. We'll talk about prescription drugs. So I want to do a shout out. 4, 5, 6, all those years ago, it wasn't uncommon for the difference in renewal rates between hospitals negotiating with carriers to be in the 5 to 7% renewal rate increases. That has a direct and meaningful impact because that's 40% of your healthcare dollars plus. A direct and meaningful impact on the rates you pay on insurance premiums and on the rates that we pay overall at self-funded plans, counties, municipalities, larger employers. And I want to give a shout out to the hospitals that have moved that to the 0 to 3% range. So can we please give a little applause here? That's meaningful. That's meaningful. Thank you. And it's hard. So we have lots of other things we're working on with hospitals, all of us together, our elected officials, the department, insurance carriers, hospitals themselves. Value-based payments, HTP, $1 billion in value-based payments to reward hospitals for transforming a what? Shutting down standalone emergency rooms. Not helpful, too expensive, not great quality. We want relationships with physicians and members. We want better types of settings, so we'll pay them to shut them down in value-based payments. We'll pay them to provide more behavioral health beds. Transform for all of us tomorrow, $1 billion in value-based payments. You'll see a new emerging transparency pricing tool And that tool, and you'll see it in the next several months, it'll show for thousands of different types of procedures. Here's what Medicaid pays, here's what Medicare pays, and here's what every single health plan that has an agreement with that hospital pays, to provide meaningful opportunities for hospitals to have dialogue with their local communities, employers, advocacy groups, et cetera, to say, whoa, why is this hospital owned by the same system 100 miles away charging this price versus the other one in my community higher? Why is this specific procedure so much more expensive than the other healthcare systems? So this is really an opportunity for meaningful conversations. I want to give a shout out. I see in the room John Bartholomew, national leading in providing this sort of work. Can we give so raise your hand there, John, don't be shy. All right, really great work that John has put a lot of this together. Nancy Dolson leads that now under John's tutelage. We also want to study some merger opportunities. We want to invest in rural hospitals. We'll talk about that in a minute. And we want to make sure that we improve the way that we use community investment dollars. And you'll see us trying to have more dialogue with hospitals to make sure that that really meets your needs as you voice your voice in your communities, and that those dollars are really directly responding to your voice. I'm going to hit a couple of these in some dive downs. So I want to talk about mergers here. So if you look at the right side, the mergers are all across every single industry now. You look for efficiencies in some areas, like Wall Street. You're going to look for profits. You're going to look for better opportunities to invest in tomorrow. Mergers can bring a lot of wonderful things. In healthcare, it's all critical, and all credible reports say it drives hospital prices up. So we need to work with our hospitals, because we now have 47 of 84 hospitals are owned by a system. Most recent, you might have seen in the paper, is University buying Parkview down in Pueblo. We also only have now less than 30% of physicians are independent. So we need to realize with these mega systems dealing with mega carriers, and we need to recognize and study the impact that that's having to our healthcare community. We also need to recognize that if you have a big system and that system is making profits in Colorado, where are those profits going when the home office is in some other state? California, Tennessee, the big hubs for where healthcare systems are owned. And we need to really think about what happens to this is a high-performing state. This is a high economy state. It's a high profitability state. Where do those profits go, and how do we address that more effectively going forward? So there's opportunity to study that. Now, we release every January report, Cost Price Profits. And it gives insightful information. This is a summary from last year's. You'll see a new one this year. And I want to point out some things that you're going to see in the next one that will change. You see big reserves to the right. You can see universities sitting on $6.6 billion, more than about a year of reserves, days cash on hand, and big profits in that 17% range. You're going to see some things move. You're going to see profits likely come down, and those big reserves are going to move pretty dramatically. So we're challenging through this hard time as the workforce wages go up, to address the seriousness of the workforce crisis. That is real. As inflation goes up, that's real. We're asking the big systems to dive into profits, dive into prices by lowering them, not raising prices. So partner to lower prices, partner to hold prices firm, dive into profits and reserves to address the current circumstance as we figure out these long-term solutions, take pressure off the wage rates, take pressure and reduce the dependence on staffing agencies through those strategies I just reviewed. This is really important. Now, what's my point in showing this? It's going to change. Why is it going to change? Same reason why your 401k is changing a little bit if you got the last reports, right? These Wall Street returns right now, the Dow down 10% year to date. This is Friday's numbers. S&P down 19%, NASDAQ's down 30%, go down few tech, Google down 35%, Microsoft down 30%. So depending on what they're holding in these big reserves, because for the first time in 35 years, bonds are down while the stock market is down. So you're going to see those reserves move on us. And so the hospitals are sitting in a very different place than they were a few years ago with these enormous increases on Wall Street. They're building these huge reserves. So we're going to see very different numbers come out between the pressures of expenses and the pressures that are sitting on reserves. Traditionally, half of the profits were coming from interest on reserves. So that dynamic is going to change pretty dramatically. And you can see just some other financials of the industry. Carriers, very interesting. United Health Group up 10% year to date. Wall Street, Anthem up 17%. Cigna up 39% in their stock price. Pharma, you can see all over the place, depending on the drugs. Merck up 30, J&J up 2, and Novartis and Pfizer down. Okay, let's contrast those big reserves of the big systems And these pricing issues that we have, and asking our big systems, dip into reserves, dip into profits, hold your prices, help all families through this difficult time. Rurals are on the completely different side of the coin. The entirety of the state is focused on helping our rurals through this hard time. 4 different work streams of money, $12 million each year for 5 years in a row, $60 million to help our rurals get from yesterday to tomorrow. It's called the Hospital Transformation Program, and the Rural Assistance Fund within that. $60 million, $24 million of 60 has already been doled out. Most recent is monies to help the rurals, all rural providers, get connected to the HIE, the Health Information Exchange, $17 million doing that. 98% of the providers in rural communities are connected. Can we get an applaud for all the IT firms and all the folks invested in technology? Thank you, awesome. $10 million now, half going to access and half going to affordability is the latest bucket of money that working on. Our department is working with hospitals and their designees to help make those applications. Those grants will start going out next year. 2 other additional things. You will see us work with hospitals rural and front range to develop cost and quality indicators. In the rural communities, what we're going to look to do through the $10 million to develop access and additional affordability tools is to help the rurals refer to each other. That will help us also close disparities in rural communities, because so many people in the rural communities don't want to come to the front range. To get at disparities, we've got to address that reality and improve the access points in rural communities. So you'll see us develop providers of distinction to help referral patterns, to keep people in the rural communities while we drive up quality, drive affordability, and improve health disparities. We're also asking our rural hospitals to partner with nursing homes. So I'm going to go 2 slides, and then I'm going to go back 1. So this is the reality of our nursing homes. So rural hospitals do not have the huge reserves that I just showed. Rural hospitals usually run a margin of 1% to 2%. And when you have these massive staffing pricing increases, rural hospitals are struggling, and they don't have a lot of reserves to dip into. The nursing homes are having the same issue. Nursing homes have little reserves. In the rural communities, they're much smaller. In the Front Range, we have some organizations that might own 34 nursing homes in the state. And so we have nursing homes that are shaking a little bit. We've had more nursing homes go bankrupt in the last year than the last 10 years combined. So this is real. So we had some temporary increases that we put in. We also have some fixed in legislation. Nursing homes have a cap of 3% increases each year. Normally that's a good thing for them, but not in this community. So you'll see in our budget that was released yesterday, in the governor's budget, there is significantly higher increases for nursing homes coming forward. Starting 23-24, we still have to get from here to then, in 3 different tiers, depending on the number of or the percent of Medicaid members that they take care of. You'll see pretty significant increases going to our nursing homes, while we're asking nursing homes to find ways to partner with rural hospitals. Swing beds in rural hospitals, how can they do? Sharing of staff, sharing of management, sharing of IT systems. And I and Bonnie Silva, who runs the Office of Community Living in our department, are running around meeting with both rural hospitals and nursing homes to try to make that a reality to get through this very hard time that we're dealing with. We've also asked nursing homes to recognize that the federal government is focused on this, which is home and community-based services. So they would like and prefer to see people treated outside of an institution, which they identify as a nursing home. So we got $530 million from the federal government, which we have plowed into in partnership with advocates, providers, the community, all stakeholders, 63 projects to transform how we take care of our older adults and people with disabilities in home and community-based settings. What's that mean? Home, we understand, might be a group home. It might be an assisted living facility in the community. That means that the nursing homes are going to struggle even more because their revenue streams, their patients will continue to come down. So we have really got to look at, because of this, because of our intention as well to keep people in the community and keep them out of institutions, you will see us focus on asking the nursing homes to change. What does that mean? It means you might have to get into home and community-based services. It means you might have to get into long-term care. You might have to get into daycare. You have to diversify your revenue stream. So as you see these big increases coming out in our budget yesterday, effective in July of next year, you will see us actively working through the legislative session, as we did last year in the legislative session, to work in partnership and to hold the nursing homes accountable for how are they going to change for the short and the long term. This is a big deal. We need to take care. We're the second fastest growing state for seniors or older adults in this nation. We have to be there and give our older adults choices choices for where they are. We also need to recognize that there comes a time in people's lives where dementia hits harder. It's harder for families to take care of individuals. We need to give people choices, and that's what we're working so hard to do. Okay, behavioral health, I won't talk too much about this because you have a fabulous end-of-day keynote speaker, which is Dr. Morgan Medlock. I have the privilege of working with her every single week. So we passed as a state, and thank you so much for your partnership on this. We sit at the bottom of the tier in many measures on how we handle behavioral health. So pleased that the governor said this is a priority. A legislature said this is a priority. Stakeholders, this is a priority. As a result, $550 million coming from the federal government that we tooled through that other $530 million, $115 million of that is going to behavioral health for our older adults and people with disabilities. In addition, $420 million. So you're talking about $550 million to transform behavioral health, memorialized through 20 different bills, changes policy, changes access, changes quality, changes cultural competencies. All sorts of wonderful work through the 20 bills that were passed and about 25 bills over the last 3 years. The Behavioral Health Administration, which Commissioner Medlock runs, that went up and running this past July. Healthcare policy and financing to stay aligned and make sure we were tooled and structured to be able to help support the BHA in driving all of this amazing change. We structured and started just a few months ago the Office of Medicaid and CHIP Innovations and Coverage, the BIC for short. Kristen Bates, you may know, has now been promoted. She's the new director of the BIC at HCPF. We're very excited about that. CDHS has renamed OBH, the Office of Behavioral Health, the Office of Civil and Forensic Mental Health. So if you hear that name, that's what that is. That's the new name for OBH. All of us rowing in the same direction to make a new tomorrow in behavioral health for the betterment of Coloradans. Medicaid, the budget that you saw yesterday, $1.13 billion. Invested in behavioral health, continual increases as we are the largest payer of behavioral health in the state and we dwarf all other public programs combined. So we need to do our part. There's also 7 work streams to hold our community mental health systems accountable. Okay, I want to touch on equity, health equity. I want to thank, again, Senator Fields for sponsoring the bill. Fantastic. This holds the departments accountable. Last June 30th, every single department had to submit a health equity plan, and we did so. The priorities that you can hear about today in the HCPF breakout session, you will hear the priorities as number 1, COVID vaccination rate, number 2, maternity, number 3, behavioral health, and number 4, prevention overall. But each area of the state and departments has their priorities, and I want to do a shout out to DOI, who has got national recognition with CMS flying in to congratulate this state on driving equity and benefits in the public option that was rolled out. Very exciting work. You'll see DOLA focused on affordable housing and the BHA stepping up to bring cultural competencies to behavioral health care and much more. So I want to talk about, we talked about hospital, I want to talk about rising prescription drug costs. So we released a report, as you might remember, and that report was in 2019 and then again in 2021, and it provided about 5 or 6 challenges to the federal government, what they needed to do to be part of the prescription drug solution. And it had 5 or 6 opportunities for us as a state under the controllable motto for us to take a hold of. So we said to the federal government, man, when these new drugs come out, you have got to negotiate those prices when they come out with the FDA. It's got to be a way to negotiate prices. It's been decades. You got to get it done. We said, hey, could you work on the exclusivity patent protection laws? How about direct-to-consumer advertising? Allow us to import drugs from more than Canada, other countries as well. And by the way, when you're negotiating prices, look at other countries because we're 60, 70% higher than other countries. Good news, first time, decades we've been waiting for this, the Inflation Reduction Act will bring negotiations through Medicare, which will have an impact to all of us beginning in 2026. And you'll see them take a shot at how do they use 10 and then up to 60 different drugs to renegotiate. They've also challenged, and this is one of the wonderful things about Medicaid right now, if a manufacturer increases a price of a drug covered by Medicaid more than inflation, they have to give us a supplemental rebate. So they can't just keep increasing the price, 5%, 10%, 10%. They have to give us a supplemental rebate, only increasing it, say, 1% or 0.5%. So Medicaid prices for drugs equal the rest of the world. That's unbelievable. They just pushed that through that legislation. Really meaningful opportunities. We're very excited to see their work go on, which that second to last one, these are state initiatives now. The PDAB is somewhat like it'll set upper payment limits. I have the privilege of being on the PDAC, which advises the DAB, and it's a whole bunch of us geeks in healthcare that right now the PDAB is looking at how are they going to pick? How are they setting up the rules? Which drugs meet the criteria of the legislation? So we're sitting in parallel, but hopefully out a little earlier, on setting the upper payment limits for about a dozen drugs a year. I also want to hit that all of these, outside of contract pass-through, which is in active negotiations right now, active study right now, all of these are in process, already up and running. So rebate pass-through was passed last session, drug importation. That submission will go from our department, a state importation program, it's called a Section 804 importation program, will be released this month to the FDA, seeking approval, and we will be all over the FDA seeking their timely approval of that. Value-based contracts, we want to continue to hold manufacturers accountable for their clinical promises. The drug prices right now, it's enough to give you a heart attack. In the last several months, 6 drugs came out, and several of them are in the $2 to $3 million range. $2 to $3 million for a drug. So we are all over that right now. The importance is trying to get those negotiated through value-based contracts down. Tell the federal government, get as quick as you can. Come on, I need you negotiating these drugs as they're coming to market. This is going to be a huge impact on all of our costs. And we want to make sure that we have got those life-saving access, but we want to make sure they're at affordable cost. So wonderful progress on prescription drugs. I want to hit one real quick as an innovation. The prescriber tool was rolled out in January 2021. The first module in the prescriber tool was to give physicians a tool to make sure they didn't overprescribe narcotics. That would be most common opioids or benzos. And this is personal to me. My father, some of you have heard this story, but when I was a young kid, my father couldn't sleep at night. He was a rising executive. He went to the doctor, and the doctor said, take this to go to bed at night, and take this to get up in the morning. That was Valium. Those were uppers and downers in the 70s. And he became addicted, and he lost his job. We lost our home. Parents almost got divorced. We had to move 3,000 miles away from California over to the East Coast to be close to our family so my dad could recover. Very difficult time in our lives. I can remember sitting as 7 and 8 years old. My father would lay on the floor in the family room, in the living room. Lights were out, and he would listen to the South Pacific song over and over. Happy talk, keep talking, happy talk. Over and over. I can remember that like it was yesterday. This tool that we put in, our utilization of Medicaid for narcotics is down 16% since it went in January 2021 with no other policies. Can we get an amen for that? 16%. That means some little kid's future is bright, and we are so proud of that. The affordability module was released in July of 2021, soft launch. We've already got 42% of Medicaid prescribers using this tool. It's available to all prescribers through their EHR, commercial and not. It gives prescribers up to 3 alternatives for a drug that is more cost-effective for commercial for the member in front of them, for Medicaid to Medicaid itself. Yesterday, our budget was released. Today, there's a copay for Medicaid drugs of $0 to $3, $0 for children and pregnant women, $3 for adults. Yesterday's budget says remove all copays from Medicaid except for emergency room, to reduce health disparities, to make sure low-income people can get the care they need. And we are defining affordability in Medicaid. No premiums, no deductibles, no copay. Can I get an amen for that? That's the definition of healthcare affordability. Well, the way you do that is we've got to have more tools on our tool belt to control the costs, because you can't give away the store unless you control all the costs on the back end as best you can. The prescriber tool helps us do that. You'll see us build value-based payments around it. The third module, or the second module, of the 2 parts that we just said are already rolled out, and we are working with all major systems and all providers to get them using the prescriber tool on the affordability module and the opioid module, because the next module is social determinants of health. The vision and the goal, and right now it is in bid. We're waiting for the RFP bids to come back. This is the reality that says we want to prescribe programs, not just pills. And it's bidding right down. That means if you have a pregnant woman, we want her in the maternity management program, we want her in a prenatal care program, we want prescriptions going out for WIC, we want prescriptions going out for SNAP for low-income people, housing supports, diabetes programs, weight loss programs, all sorts of healthcare supports. So it's programs that gets down to the functional medicine part, and this is real. And when this gets up and running, certainly the first primary focus is low-income individuals eligible for Medicaid, but it can be used by every single doctor and case manager. Very excited about that. All right, a couple more innovations, and then we'll bring it to a close. E-consults and cost and quality indicators. So we said in the rural space, providers of distinction. We want to make sure that those providers know where to refer for cost and quality. That will go on across the entirety of the state. It's bidding right now. We're about to make a decision of whose tools we use to identify cost and quality indicators. Then we want to make sure those are available, called providers of distinction, to all providers so they know where to refer. The e-consults gets in front of that, and it says, especially for Medicaid, again, we've bid it, the bids are back, we're making a decision right now. It says primary care physicians, you have a Medicaid member in front of you. It's the best place to provide the most care that we can. When we set up a specialist visit 6 months later, or 6 weeks later, we often have a no-show. These are moms with carrying 2 jobs, 2 kids that struggle, trying to get off work, hard to juggle that. The most care that we can provide in the primary care setting to close those disparities, to improve that quality, to get at affordability, that's what we want to do. E-consults allows that specialist consultant to be in an asynchronous and sometimes right at the time of the visit relationship with the provider at the primary care level to make sure they can get the support they need to care for the person in front of them as best they can in that setting. We know we can improve access by that. We know we can improve the closure of disparities and equity. We know we can improve quality for that. So we're very excited about that tool. When the referral is necessary, we want to plug in those cost and quality indicators so it gets to the right outcome, again, to achieve those same shared goals. Very excited about that. All that is going on right now. If you make all this work, and we have to make all this work, you pay a value-based payment. Why do you pay a value-based payment? Because you get what you pay for, and we need a different tomorrow. Yesterday is not good enough. We need to close those disparities and pay providers to do that. We need to improve quality and pay providers to do that. We need to improve access and pay providers to do that. That's why CMS says by 2025, they want 50% of Medicaid payments and value-based payments. Why? Because all across this great nation, Medicaid programs are the biggest in each state. And when they move Medicaid, and 1 in 4 Coloradans, and we have one of the best economies in the country, go down to Louisiana and you'll see it's a whole lot higher than 1 in 4. It might be 1 in 3, it might be 1 in 2. When CMS moves the industry by holding Medicaid accountable, that's what it does. It's not just moving Medicaid, it's moving everybody. So the commissioner and I, Commissioner Michael Conway, joined at the hip trying to make sure that we stay in tandem. That first indicator I said, HTP, $1 billion in value-based payments for hospitals. It's not changing it for Medicaid, it's changing it for all of us when hospitals make those changes. But we also have cost and quality indicators. Primary care, yesterday's budget released for primary care, if primary care physicians join in Medicaid, or you're already in and we're paying you a fee for service, if you move into value-based payments that moves you to partial or full capitation, your payments will go up by 16%. Why? Because we know when this primary care model goes in, and it's already in, we already have physicians signing up right now. When that goes in, they can afford to implement all the tools that we just went through. The prescriber tool, the e-consults, the cost and quality indicators. 16% increases. Why? Because primary care is where we get the best quality care, where we have the best relationships, where patients have the best integration and relationship with their doctor. We also want to make sure that primary care doctors are integrating with behavioral health. This money's allow them to do that. We've got $39 million in additional grants that start next year to help primary care integrate and provide the behavioral health access of care. Maternity bundles, prescription drug, value-based payments. We even have nursing homes already on value-based payments. Behavioral health is in development right now. And that all comes together in what we call an accountable care collaborative. It's bidding in 2025. I should say it's awarding in 2025, bidding in 2023 and 2024. This month, we start active stakeholder engagement after it went through the health cabinet, got good feedback. We are in a very good place right now in order to achieve these goals through the skeleton model, which is draft. It needs all of your input to get to finalization. But the goals are what you heard Carter say: improve quality, close disparities, increase access, improve member and provider service, and manage our cost trends. Why? Because we want to protect the benefits we have at Medicaid. We want to protect the provider reimbursements. We want to protect the eligibility rules that we have. We don't want to go to draconian alternatives when we go into economic downturns and have to take away benefits or reduce provider reimbursements. Those are not the right strategies. That's why the value-based payments are so important. That's why these alternatives we just said for innovations are so important. And you'll see us also with this new model that comes out for ACC 3.0. It will include all of the good work of all the other departments. Public health, what are you doing? CDHS, how you treating behavioral health? The BHA, where are you? Commissioner Conway and value-based payments, all of us working together. You'll see an amazing integration with all the other departments. Last year was historic for a legislative session. Historic, I won't cover this, but see just the pandemic, behavioral health, affordability, coverage. Again, shout out to Commissioner Conway for the public option. When that collar option goes live this January, it's going to be pulling down costs by about $15 million as projected. And can we give him, when you see him, give him a shout out for that good work. So no, that was a historic session. This session's going to be historic, and each one coming after it because we have a lot of work to do. And that work to do is a credit to all of you. I want to thank you for being in this room today because it means you're engaged. It means you care. It means you are trying to get up to speed on what. It means you are trying to make a difference for tomorrow, and we need every one of your voices, every one of your beating hearts, every one of your brilliance, your intellect, and your blessings to make a better tomorrow. We've got a lot to do, and I appreciate who you are and that you're here today. Thank you very much for your time. I appreciate it.
Yeah, we've got microphones back here. We're already eating into your potty break and your coffee refresh. But with that as a primer, right? This is what we're going to go do. This is what we're all already in the work. I want to say thank you for the work that you do for Coloradans, and obviously the impact is tremendous. 2 questions.
And no, I'll
Who
be
wants
here,
the
I'll
first
be here all
one?
day. That's the goal. I'll be here all day.
If nobody raises their hand, Senator Fields.
Rock star, Senator Fields.
Good morning, and thank you for that presentation. It makes me really proud to be a citizen of the great state of Colorado and to be able to serve under the leadership of Jared Polis, and the work that you're doing is phenomenal.
Thank you.
When you just went through all the slides, I think about all of the things that we've done in the state. And so my question is, in Colorado, we're seeing a very aging population. And with that, I'm seeing many people in my community dealing with issues of mobility, dealing with issues of not being able to afford prescription drugs, having to make all kinds of decisions about affordability. And some of it has to do with housing, some of it has to do with food insecurities, and I'm just wondering how that plays into your work and the work that still needs to be done to address disparities across our state, because we're still seeing how there's a spotlight there since COVID. We've seen the impact that it's had on people of color.
Thank you very much. Several areas. One, I want to thank you again, Senator, for your leadership in finding that balance of controlling costs, improving health equity. We have a lot of work to do, but the good news is the entirety of the state with Governor Polis is focused on saving people money. The first was saving people money on health care, but that saving people money has iterated across housing, has iterated across the economy, because we have to recognize families are struggling, businesses are struggling. The neat thing about focusing on health care is when we have the healthcare solutions, they're the same solutions and problems at the federal level, the same solutions and problems at the state level, same solutions and problems at the employer level, and same at the family level. So we are all in this together, and that's why there's so much focus on that saving people money on healthcare. But for the first time, the value-based payments, we're so proud, again, of your leadership, Senator, on the equity bill, but you'll see in all of our payments for value-based payments, it's driving and rewarding people for closing health disparities. That is absolutely paramount. Our maternity is a value-based payment as we try to get that across the finish line. We'll be the first in the nation that does that. And as you know, 250% higher mortality rate for individuals that are people of color, black people specifically, and maternal death than white. That is not okay, and we're paying providers to change, and we're covering doulas in our budget released yesterday to try to get at that cultural competency to bring a better outcome for tomorrow, and it's a good rate for doulas as well. So I appreciate your leadership. I appreciate those questions. A lot of work going on and a lot of collaboration in the room, and I look forward to this session and continue the hard work with you.
Okay, we've got one more already queued up here.
Hello, my name is Maureen Welch, and I'm a parent of a child with intellectual disabilities, and I'm also a CNA for my son. And I so appreciate Medicaid and all of the programs that are available to him and the leadership of our legislators, excuse me, coming off a cold. And I just have a question for you. We have a real crisis right now, and for any of you that haven't heard about this, you can read Jennifer Brown's article that just came out last week in the Colorado Sun. And the problem is that Medicaid is denying pediatric home health nursing to our most disabled of children. And they're doing this because they have a third-party, I guess you'd call it a utilization management company who's reviewing the requests. And we have children who are on ventilators, who have round-the-clock care, suctioning. They can't eat, they have G-tubes. And these are the very children that are getting 80% of their nursing denied. And my question to you is long-term care, home and community-based services, they're critical for individuals in my community and my son. But I feel like the subcontracting of a public agency to a private corporation, and now we've moved that office into the Office of Community Living that doesn't have any medical expertise. I'm very concerned about the outcomes when I see hospitals making 17%, and you're cutting off income and services. And actually, Children's Hospital, I just talked to someone whose child was admitted to Children's Hospital because they can't get home nursing at home. That's not saving Colorado money. That's costing Colorado money.
So let me address
please.
that, Maureen, for the sake of time. I appreciate it. Maureen, I appreciate you and your son being a Medicaid member. I appreciate your passion and your advocacy. KeyPro, which is our utilization management firm, has no profit bearing. They don't get payment, more or less. They're doing the best they can to make sure that people get the right care that they need. We have doubled down, tripled down. There's 2 more meetings with advocates and with members themselves over the next 2 weeks. We've got about 7 work streams making sure people get the care they need, but we also have periods of time where this current status of the care that they need is different than the care that they're getting. And so you'll see us continue to make sure people are getting the right care at the right level, at the right hours. We also know that we have an opportunity that some of our agencies that plan and give that care aren't doing the best job that they can to actually make sure that the information is in the hands of KeyPro to be able to do that good review. So you know that we've had many meetings with this, so we'll continue to have meetings as we address our opportunities and in order to achieve our shared goals, which is make sure people get the quality care that they need. And again, we're covering 43% of the kids. Kids are in our heart every day. So I'll leave it at that, but there's other opportunities to have more meaningful dialogue on this. Thank you again, everybody. I really appreciate it. I'll be here all day. Appreciate your service.